Pain, that medically elusive evil. What about changing the focus from controlling pain to understanding pain as more than a symptom? Can pain be cheated? My name is Dr. Dean, chiropractor and physiotherapist. My goal is to reframe how medicine understands pain to improve care. This podcast series is dedicated to a same-day conservative treatment for low back pain. This podcast has a companion published article number 6. Welcome to the Pain is Not the Only Problem podcast. The essentiality of conservative care is being reevaluated. The contributors to patient symptoms are being re-explored. All options are on the table. While it seems tempting to skip ahead to discover the treatment that I recommend, you will miss the value of the clinical journey that I am sharing with you. Article 6. Pain is not the only problem. Chemical and immune contributors. These articles intend to 1. Reevaluate the prevailing clinical practices thought to manage low back pain. 2. Submit and debate novel low back pain contributors and mechanisms. 3. Meet patient expectations and satisfaction and clinically meaningful results. 4. Recommend a conservative, non-surgical course of care to override pain instantly. And 5. Restore ADLs and patient confidence on the first visit at low cost. Traumatic low back pain aside, there are 6 possible categories to organize low back pain contributors. Classical orthopedic exams would likely not rule out these. Number 3, chemical, and number 4, immune contributors. When clinicians think of low back pain and chemical contributors, they should be thinking inflammation. Inflammation is simply the natural immune reaction to acute tissue damage, for example, a fall to the hip, or a lower seatbelt impingement due to MBA, and is designed to mediate further tissue damage or infection and to restore the normal tissue repair process. This process typically takes 4 to 5 days in healthy persons without comorbidities to healing, such as prior metabolic diagnosis, including diabetes mellitus and neuropathic arthropathy, and lowered immunity, such as in arthritides, and poor diet, including high histamine diets, poor gut biotics, and alcohol use. When inflammation is unresolved and tissue repair is unsuccessful, chronic infiltration of inflammatory chemistry persists and destroys low back pain joints, which is seen in synovitis, paniculosis, and arthrosis, and joint function. Instability and pain follow. The lumbar spine is particularly unique since it is chronically loaded axially with gravity, with the articulations being compressed and commonly malpositioned due to polar or the path of least resistance. Without resolution, the onset prevalence of inflammatory mediators stimulates the sympathetic nervous system to amplify adrenal function and cortisol production known as sympathetic syndrome. This cascade of sympathetic amplification adds to the state of chronic pain since GABA is interrupted and inflammatory chemistry persists unmediated. Nociceptive modulation, top-down, becomes insufficient to deal with escalating sympathetic amplification, and soon the patient is experiencing low back spasms, sometimes as trigger points, due to oxygen-starved hypertonal low back muscles, particularly the erector muscles, a condition known as sympathetic ketonia. This is the sympathetic nervous system producing a toned muscle condition, sympathetic ketonia. Trigger points are oxygen-starved bundles of isolated muscle that are not contributing to the normal contract-relax motor cycle. Instead, they remain contracted in a negative oxygen-starved coma, unable to produce important proprioceptive feedback such as gamma gain, stretch, and muscle tone, or follow central control. Motor control attempts to fire around the damaged tissue leads to SCAD, sympathetic compensation to associated dysfunction. So you're starting to hear some of the same words over and over as we dive in deeper into this journey. Chemical changes begin to occur within the joints, ligaments, and tendons as calcific or ionic salt deposits, interfering with joint function, range of motion, and comfort. Chemical changes can occur at the cortex of the vertebrae. These changes are attempts to stabilize an unstable, weak spine because the patient does not sequence core neutral prior to distal motor patterns. I do not agree with the terminology degenerative changes, since this language suggests that the spine is degenerating, falling apart, aging, crumbling, moving away from that pristine, perfect spine model, of course, that no one has, not even me. I would prefer to term it responsive changes instead of degenerative changes, since the spine is reacting to usual loads, whether useful, unuseful, or incidental, and whatever movement the spine does most days. The clinician can't just point to osseous change on an x-ray with a pencil eraser and blame the observed changes for the problem. Osseous changes respond to patterns of use, either casual or forceful, and the spine's total clock time spent with ground force reaction and prevailing chemical health, whether inflammation, diet, etc., and how many times the spine has changed jobs. What does this mean? A job is a chunk of time that the spine's primary experience is the same. For example, years of standing at a job. Then the spine's job changes when the spine is seated for years. The spine is primarily experiencing a change in loading. Degenerative change is a slow, methodical evolution of the chemistry of the bone to adapt to loading jobs. I have a patient that was a landscape contractor for 12 years. He was primarily in a half squat position and dug holes with his arms all day. Due to chronic carpal tunnel, he switched careers to be a personal trainer for 12 years. Then sat in grad school classes for 4 years, then became a tennis player. The patient's spine had to change 4 times to adapt to completely different loading and use pattern periods. How many times can the spine change jobs until it just can't skeletally adapt anymore? Osseous changes seen on plain film and advanced imaging are chemical changes. Bone remodeling is a chemical process. How would a surgeon expect to physically case manage a spine when the process is chemical? Chemistry has an important contribution in low back pain diagnosing and case management. I would venture to say every attempt to case manage low back pain without looking closely at patient diet, gut health, blood labs, spinal loading habits, patient awareness of core neutral, and how many times the patient's spine job has changed over the lifetime is futile or possibly neglect. The number one comorbidity to low back pain is smoking. Think on that, chemistry, because pain is not the only problem. Thank you for joining me today. Let's advocate for improved patient satisfaction and for the profession. Let's demonstrate a cross-cultural willingness to strengthen medicine. Thank you very much.